It is a beautiful day. It's almost a shame to come in and have this meeting inside as we're looking out at the beautiful weather. I hope everyone's been enjoying it. Thank you all for signing in the chat. If you have not yet, go ahead and please put your name and affiliation. It really helps me with the attendance. And as many of us are coming into site visits, we all know how important that attendance is. So if you want your name on the roster, put it in the chat. Is there anyone new today who has not been to an ATAB meeting before? We actually have quite a few here in the room. So why don't we go around and introduce ourselves? You want to go first? Sure.
They were just gonna introduce.
I'm Megan Lunenberg, I'm the trauma surgeon and chair of ATAB 1.
I'm Natalie Booker, I'm the director of trauma and ED at Emmanuel.
I'm Andrea from Emmanuel, also a trauma PI nurse coordinator.
I'm Allison Bitterick, also from Emmanuel, trauma nurse coordinator. PI.
I'm Jesse Garcia, also from Emmanuel, trauma nurse coordinator and PI. Sarah, at Emmanuel and injury prevention.
Valerie from Emmanuel, also a trauma nurse coordinator for education and outreach.
Good afternoon, I'm Jordan Tiller from Legacy Emmanuel, I'm a trauma nurse coordinator for education.
That's where the top version of issue.
Trisha Lee from program manager.
Elena Romeo, current program manager, Emmanuel.
Becca Brown, OHSU PI.
Jody Berryhill, OHSU PI. Heather Wong, OHSU trauma program director.
Hi, my name is Matt Kirk. I'm one of the OHSU councilors, the vice chair, and we definitely set up like super antagonistically.
No, we didn't.
Oh,
I'm Emmanuel TPM.
oh, good for you.
That's what I'm sitting on.
Good.
Matt, come on.
Should we just like?
Did you
all
listen to my
move-
intro?
Should we just all move seat? No, I was like, actually commenting at the beginning, like we all sat on the same. Never mind.
All right.
Hey Megan, this is Stella. Since there is such a large crowd in the room and we can't see everyone, when somebody speaks, could they just state their name? That way we in the virtual world can know who's talking. That would be helpful. Thank you.
Absolutely. Absolutely. Is there anyone new online? Well, thank you all for coming. For those of you who do not work here, is this your first time at OHSU? Raise your hands. First time up here?
In this building, yes.
In this building, yes.
I put on my cap and gown for my graduation in this room.
Oh.
Before you go into the auditorium. So, fond memories. All right. Now that we've done introductions, we can move on to announcements. I don't have many, so this is your turn, Stella.
Really? No big announcement? Weird.
Oh, I can do that.
I mean, there's the elephant in the room, but
And
we'll deal with that
definitely be
later.
reported in the media later today if it hasn't been already.
I'm sure we'll end it. We can.
Oh, it is. It's already out.
The merger between Legacy and OHSU is no longer going to go through. They've decided that they will exist better as and serve the community better as private entities, is I think how they framed it in a very vague email that we both got today. That in no way changes the fact that we will continue to work collaboratively together to serve our community for trauma, whether we are one system or two separate systems working together. And this is a great forum for us to do that. So that's my only real announcement that everyone here has already heard.
That was well put, Megan. Thanks. It was more of a joke, but anyways, hello everyone. For those of you that don't know me, my name is Stella Scott. I work for the OHA EMS program. I manage committees, cardiac arrest registry, and the stroke registry for the state. So a few things happening this week. So we are on our way to having almost all of the committees and boards starting. So Nicole Perkins and myself have been working very, very hard behind the scenes to make sure that it's going to run as smoothly as possible, as we have, I don't even know how many, 4 5, 6, 7 new.
7 meetings this week.
Yeah, 7 meetings this week in 4 days. So among some other things that are happening. So very exciting. I see a lot of faces and names on here that we are excited to have you join and represent your profession and your community and your affiliation. So that's
Pause on
happening.
that for just a sec, Stella, just because there may be folks on here who haven't gotten the run through. So I'll go super fast and just say, for our schedule for this week, Tuesday is going to be the EMS Advisory Committee in the morning. On Wednesday is our time-sensitive medical emergencies day. So our morning has 3 simultaneously occurring subcommittee meetings: trauma, stroke, and cardiac. And then our main time-sensitive committee meets in the afternoon on Wednesday. Thursday morning is EMS for children. And then Friday all day is the EMS Advisory Board. So very quick overview if folks have not interacted with our program before, have not heard or want to know what the 7 different groups are that are meeting, those are the 7 of them. If you have specific meetings from that rattle off that you want to attend, you can send me a message and I'll send you attendance information.
I actually put the link to our website that has all of the links, the agendas, the slides that are going to be used for all the different meetings. So that is what I just entered. And thank you, Nicole. Yes, it's quite a bit there's quite a bit that's going to happen and take place, but we're really excited. We are also in the middle of licensing season. So, we are licensing EMTs through paramedics. It's about 8,000 plus licensed providers that our agency is renewing for the next 2 years, as well as all of the agency's renewal period. And that includes all of the ambulances in the state. So job security, 100%. But we are very busy, so we appreciate everybody being patient as we're trying to get back and continuing to do the work that we've already been tasked with. We also have a lot of different projects taking place. Our data team is growing, and I will let Adam talk on that in just a moment about what's taking place with that. I also wanted to give an update on the conversation from the Big One discussion that we had at the last ATAB. We did follow through, had discussions both internally and with the different experts in that field, and have made an adjustment to identify that it is for adult patients only. So we will put the link in the chat for for the new letter with the update on it, highlighted very, very bold with a little blurb that says we have updated this to be for adult patients. So we appreciate that you all had that conversation and brought it to our attention. And yeah, hopefully we are going to tell all of the different ATAPs as we move through, but that was one of the follow-ups from the meeting. And then I think that is going to be it. This time there's so much going on, but a lot of it is around the boards and committees meetings that's taking place. And yeah, Adam or Madeline, do you have anything that you want to update on that you feel?
Yeah, you covered most of what's going on, and there's plenty more, but
Yeah.
I think that's a great for this group. Sorry, Adam Wagner, EMS Program Manager. With the data team, I think it's important to know that the contract with Image Trend for patient registry system is finally finalized. That has been a longstanding deal. So preparations for transition are underway, including all the legacy data review and migration, identifying reports in the current Trauma One system, and auditing accounts. So they're looking to get most of the migration of the legacy data done by October 1st, 2025. I know Peter and team don't necessarily like to put dates out, but that is going to be the date that they're looking to get that legacy data squared away and migrated. I don't think I have much else other than that it's going to be a hefty week. I'm super proud of my group. Super proud of the work that's been put into this. Maybe House Bill 3572, a little bit on that. That's the new EMS Modernization Bill Part 2. That's the Representative Graber bill. They have requested funding for REMSABs that will help support EMS and pre-hospital projects. So there's going to be some, the assumption is that if the bill passes, that there will be kind of some decentralized money that happens there. They're going to extend the rural health emergency service tax credit if it goes through. EMS mobilization is also on the docket, and that has a lot to do with really the management of that is still a little gray, but the governor and the state fire marshals are involved in that. And then loan repayment for EMS providers is another one. And we also will be on the hook for a 10-year strategic plan to come out of our office. So we'll be busy with that bill if it does pop through and we get all of our fiscal for it. We're really anxious and excited to see what it asks for a lot, and we're really anxious and excited to see what kind of support we will also get in that space, human resource support. So, but that's all I have. I don't want to take any more of this group's time. Thank you.
Right.
So can I ask, this is Mac, can I ask a logistics question I should know the answer to, but I don't?
Mm-hmm.
Who's in charge of the ATABs now?
Me.
Is it you? Does it
So
go through
ATABs? Yeah, so ATABs will be giving updates to the subcommittee TSE for subcommittee trauma. And that's where your updates, instead of it being at STAB, we have a spot for updates for ATAB, for the different ATAB meetings to go to that. Oversight, though, is still with me and our program.
Right, but the trauma subcommittee for the time sensitive emergency medical conditions
Yes.
is the new staff.
Yeah. So the intention is, and there are many filters and many paths that this is going to take in order to make it actually happen. But the plans that you will be reviewing will actually, the bill states, or the Oregon law states now, that the ATAB plans are actually approved by the MSAB. But those are not the people who are have the knowledge around trauma. And so the different specialties that are going to be written within that plan are going to be reviewed by those subcommittees with the recommendation, and the recommendation has to go up the line. Again, there are going to be a lot of different paths, but that's kind of the oversight of how we see the different subcommittees supporting the ATABs in that work. But overall, it is MSAB, the EMS Advisory Board, that has the overarching governance over the committees.
It was the vision that each of the subcommittees are going to create an ATAB-like structure, like
I think it's going to be
SAB for strokes or whatever.
Yeah, I think each group, eventually the ATABs are going to be REMSABs. They're going to be the regionals of your different specialties. There's a lot of different talks of how that's going to work, but we do want that cohesiveness between the different TSCs that write into that plan for the overall region. So how that looks, we really haven't gone down that rabbit hole. We've only looked at it from the very high levels of how are we going to do this. But that's why when we started earlier this year, that is why we're asking you about the different TSCs within your region. You may or may not know of it, and that was totally fine. We had areas that had no clue about the other types of TSCs, some that did. So we're just trying to get a pulse on what is actually happening in order to create a structure that is going to work for each region, as well as a whole state plan for each of them. So I know that's not like detailed, but hopefully that kind of gives you the idea that we're still trying to design it, but we're going to get input from all of the different ATABs as well.
I think Wednesday will be really telling too. We'll be able
Yes.
to have a lot of conversations about referral patterns, how they fit into the ATABs. So the conversations are just going to get started on all of these details. So should be exciting.
Did I create more questions, Mac, or did I answer them all? Yep.
We're gonna try to switch to a Bluetooth device so we can all hear better.
Okay.
Just a sec here. Is this
How's that? I heard a,
Hold on, we're switching.
okay.
Albert told me you're going to New Zealand for a year.
Yeah.
I'm jealous.
That's a.
Really?
Meet Luna?
Can you try talking now, Stella?
Sure.
That's
Love
much
to talk. Nicole got to experience my testing voice when we were trying out all of the rooms for our TSC subcommittees. All right, we're good? All right, any other questions? Or we put a lot of links into the chat for those that are able to access that online. There's the House Bill 3572 that Adam spoke about, which is the modernization part 2, the board and committee information, the whole list is there. And then trauma education big one update where it's located on the website, as well as the updated document link is there. So thank you. I'll hand it over, Megan. Thanks.
All right, so the other placeholder I have is our ATAB plan, but they are still working on it on the state level to give it back to us, so I don't have anything to actually say about that. I've been more wishful thinking than anything else. So then we've got a lot of space left to kind of have some conversations about what we would like to do with our last 2 meetings for the end of the year. And I have some ideas, but if anyone else has ideas they want to start with, I welcome that discussion.
Hey Megan, it's Jill at CMH. I think it would be good to, I don't know if you heard, but we got recommended to be a level 3 trauma center here on the coast. And so eventually we need to talk about some of the injury patterns that we should be keeping here instead of using the level 1's, valuable resources. And I think big is a great place to start. So I'll review that document in greater detail, but just clinical practice guidelines for level 3, because now we're the first level 3, I believe, in ATAB 1.
Congratulations.
Yeah, that's really exciting. I think that'll be a really great resource for the coast. And the general area that your catchment area. That means that we're actually going to have to define a catchment area for the coast. It means we're going to have to put into our ATAB plan which patients stay, which patients to be transferred. Look at all this ATAB plan editing that we're going to have to do.
Darn.
It's actually a good thing. I think that that's kind of really how to integrate the hospitals along the coast with the system in the metro area. I think is one of the weaknesses of our plan, because essentially right now it just says send them, but it doesn't give a lot of guidance into what hospitals people should go to or this necessarily how the sending process happens. So I think that's a really great opportunity. We'll have to work on that going forward. And then I believe our next ATAB meeting is at Columbia Memorial, is it not? Yes.
I think so.
Yeah, so we'll get to have that conversation in person at your home facility, which would be great.
Megan,
Sounds good.
Yes.
just to confirm, usually the coast one is on a Friday, but if you had it during the week of the state meetings, you would be overlapping MSAB. So is that date changed for ATAB 1?
Every time I put it on a Friday, nobody comes. Everyone
Oh,
says,
no. We went last year. There was a lot of ice cream. You muted or it went quiet. There we go. Okay.
Um,
My mouse.
No, I think we're good now. I can hear.
we kept ours on a Monday. Would anyone prefer it to be on the Friday?
It's the
Remind me what day it is.
August 11th, Monday, August 11th. Monday's good.
Yeah, I think with all of the other meetings and obligations that we have with the new PMS modernization and structure, it's gonna get even more complicated to try to move it. And so when we picked these, it was so that it wouldn't overlap with any of those other meetings.
Yeah.
So we'll just keep it. I think most of us do it as a day trip anyway. I know we have, and still plenty of time to enjoy some of the local delicacies, ice cream or otherwise. We'll have to get recommendations for what's the best thing to get in Astoria is.
Great. Thanks for that confirmation. I appreciate it.
On board.
Yeah, boardwalk.
Does anyone else have anything they'd like to bring up? So Mac and I have been talking back and forth through email a little bit about some big one criteria to look at. And I think that kind of separately, we've both been considering how much we think aspirin acts as an anticoagulant is a big criteria. And if keeping it as the strict initial big guideline is potentially still leading to more transfers than are clinically necessary based on the risk of progression. So the situation we've been having is having conversations with Silverton and other legacy hospitals about coming up with a defined in situ guideline that builds from the state recommendations that are published. And our ER docs at Silverton specifically keep saying, but the data is coming out that says we don't need to do this. Can we push these boundaries? Should we be different? And from our standpoint, it's hard for me to treat them differently than I would treat any other hospital I'm taking a consult from, but it's something I'm certainly willing to consider, and I think we should discuss. And then share your story.
Yeah, so this just happened here, 3 or 4 days ago, where Tillamook admitted a patient who had a 2 millimeter subdural, which meets the big one criteria. They were on 81 milligrams of aspirin. Our guideline, like here, our guideline was stratified, that's still the big one. For reasons that are not entirely clear to me from the chart review, they got a repeat CT at 6 hours, which is not what we would have done, but at 6 hours, that subdural went from 2 millimeters to 5 millimeters, and because it was 5 millimeters, that initiated a transfer. They came here, they got a head CT, it was 5 millimeters, they're on the ward, they're gonna go home. I think there's 3 different ways to think about that. The first way is that's entirely consistent with what we know about big one traumatic brain injuries, which is some percentage of them will have some small amount of expansion if you image them, but that's never triggers anything other than ongoing observation, which is exactly what happened in this case. 1. 2, in the absence of a significant, in the absence of clinical change, that there's probably a lot of people who this happens to, who we just send off on their merry way and never know about. And so without it, is the ostrich approach reasonable? Or 3, should we just continue to make aspirin, regardless of the dose and regardless of what institutional guidelines may say, make aspirin or ATAB risk stratification to big 3? I don't think when we wrote the STAB guidelines or the STAB recommendations that we included the 80 like an 81 milligram of aspirin. So if you look at the STAB recommendation, any anticoagulant use results in risk stratification to big 3. But that's also intent. I think we chose the words when we wrote that to allow the ATABs to implement that as they see fit. I have a thought and a consideration and a recommendation, but curious what other thoughts are. I also don't understand if someone will come. Okay, my recommendation for ATAB 1 is that if we can be sure they're taking 81 milligrams of aspirin, that doesn't seem to be in and of itself a reason to trigger risk stratification to big 3. Like, there's a pretty good set of data out there that those patients behave very similar to big 1 traumatic brain injuries. Now, and so we can include an asterisk that's like, if the weather's bad, right, and transfer is going to be super long, maybe send them, or maybe, you know, create some like big 1.1 where you observe them for 6 hours and get a HCT, but that seems an awful lot like big 3. So my recommendation might be someone's on 81 milligrams of aspirin, either decide if you're going to treat them like a big 1 and treat them like a big 1 in its entirety, or re-stratify them to big 3. But I would recommend the prior first one. I'm also not in charge, and I don't want to be in charge.
Yeah, this is Brian Beldowitz with Legacy. I mean, I agree with that for a couple of reasons. Number one is that, again, you're right. I think the evidence does support that they behave like big 1, and obviously, if they're multifocal or larger, they're going to get, you know, automatically categorized as the 2 or 3 based on the size of the bleed. So if you truly have what would otherwise be a big 1 hemorrhage, the fact that you're on aspirin, I think, doesn't increase the likelihood of you needing a procedural intervention, nor is there like a time-sensitive intervention, such as either neurosurgical intervention or reversal that is implemented in the case of aspirin. You know, the recommendations do not recommend for platelet administration if you have a head bleed on aspirin and those sorts of things. So again, I think the prognosis being closer to a big 1 and the lack of the need for a time-sensitive intervention means that I think it would be a more efficient use of resources to categorize them as the big 1. So I would agree with you.
Brian, do you think the dose of aspirin matters?
Evidence-wise, I guess I don't know the answer to that, but part of it I think comes back to what is the indication for the anticoagulation? You know, I mean, an indication for an 81 milligram aspirin sometimes is just, I don't know, age or something. But if they're on 325, it's usually because they have some other high risk feature, whether it's a prior stroke or or something like that. So I guess, I mean, I think I might be more willing to say if we confirm that they're 325, that they might do better at a higher center, only because they've got some other risk factor that makes the 325 necessary, more so than the dose itself, if that makes sense.
Yeah, I think I'm inclined to agree. I think our guidelines here would stratify them to big 3 if they're on 325. I noticed that we missed it a couple of weeks ago.
But I think what I would do is I would make the default saying that unless you can conclusively, confirm that they are on the 325, that they be categorized as if they're on the 81, which is the far more likely situation. Because otherwise, if you can't confirm a dose and you automatically assume 325, I think that's going to lead to an overuse of resources.
I think our guideline left it intentionally vague. Our practice certainly reflects that we treat 81 milligrams differently than 325. I think the first question for this group is how many at a level 1 center would discharge the big 1 on aspirin, provided they didn't have another reason for admission? Jack and I, wonderful. Brian?
I'm sorry, I didn't hear the phrasing of it. So
if they're a big 1 on 81 milligrams of aspirin and have no other indication for admission, would you discharge them?
I would discharge them and tell them to continue taking their aspirin as prescribed.
Justin, what would you do?
I think, unfortunately, we're trying to make a statement about a broad age group. 50-year-old that has no functional comorbid conditions or frailty issues would be on 81 milligrams, and a 90-year-old who Maybe a mechanical fall risk will be an 81. And so we're trying to make a decision on what to do with the patient when the patient doesn't really obey the algorithms. The algorithms didn't really take into effect the frailty or fall risk of the patient. And so the difficulty in making a blanket statement is some people will look at a patient and be nervous about sending that patient. I want to know this particular case. And so they'll get the follow-up just to make sure it's safe before they send home, because there's something in them that's saying, I'm afraid. And so the question will become, when we create these algorithms, is there an extra step or two that we can make the places feel better, i.e. you get PT to clear them, or you do a like, is there something you do so that that team feels confident that this patient's not going to get worse? Now, it may not be that the bleed gets worse. Like, I mean, the bleeds always get worse when they come back, but we don't know why. Did they fall again? Did they, like, we don't know, because they always fall again because it gets worse. We just don't know that the fall make it worse. Was it getting bigger? They lost their balance. Now they were having some sort of hemiplegia that led to, or hemiparesis more likely, that led to instability. So that's where this gets difficult, in my opinion.
I think the point that I was trying to come up with was, if we are not comfortable discharging them, it is unfair to then ask our colleagues in other hospitals to then immediately discharge them when their volume of what they're seeing is lower. So their comfort with this population is less just by default. And so if even we are not comfortable assessing their fall risk and their safety and all of those things for however else we're going to determine if they're going to go home, just purely on their head bleed, if we're not comfortable, then we shouldn't ask that of anyone else. Because I think ultimately this is a partnership between those of us who have neurosurgeons and those of us who do not have neurosurgeons. And I want to make sure that whatever recommendations we are giving comes with the confidence from our side that the recommendations we're providing are safe for their patients, so that they don't see bad outcomes and have that person immediately come back, because then it breaks our trust.
Yeah, one patient coming back.
Yeah, that's why I brought this up, right? I'm just, because I'm afraid that this could be that patient. What if, you think it'd be reasonable to say something like, a patient who otherwise meets big one risk criteria, risk stratification criteria, that is on 81 milligrams of aspirin, that should trigger some reason for discussion, but not automatically transfer. Because I think the matter, like, I mean.
Yeah, I think, I agree with what Megan said in that I think it's a good use of potentially using the like a trauma consult rather than a transfer, because ultimately what I'll often discuss with the providers is say, if this exact patient had come to my ED with these findings on this med list, I would discharge them home. So why would you subject them to a transport in 2-hour travel time and all that sort of thing? Whereas if they had come straight to me, I would discharge them. And oftentimes I think they are reassured by that. So yeah, I think maybe the utilization of the system, the consult system, rather than the transfer rather than as a transfer request, I think could help bridge that gap.
Even if they need to be admitted for failure to thrive at home or other medical reasons, a lot of the trauma patients with these more minor, small injuries that we have, the reason we're admitting them has nothing to do with the risk of their injury and everything to do with how they got it and preventing it from happening again. But I think we definitely need to have this conversation, including some of the providers from our other hospitals. Do we have any ED docs on anywhere?
I mean, even though I'm OHSU, I work at Adventist, which is not a trauma center. So I think implementing the big one is generally appreciated. I think you run into a lot of challenges if you need to admit that patient for other reasons, though, because the hospitalists become very sneaky or very concerned about it, even though you would have sent them home with that bleed. They just don't like having that patient with the bleed sitting there. The same thing happens with rib fractures. We get someone that's old, they fall down, they have 1 rib fracture, 2 rib fractures or whatever, and they're being admitted because they can't walk or because they have a UTI or something. The hospitalists don't want to admit them because they have rib fractures, they're trauma patients. So that's another layer of resistance that's really hard to overcome, but conceptually, I think the people like the big one. And I think it works well. And actually being able to do it via trauma consult over the phone is really nice.
We should certainly reach out to CMH and fill them up before we fully move forward, as they're certainly in this ATAB and the voices are valuable. We'll send that out, I keep discussing this, and then eventually I think it's something that would be good to propose to the new trauma subcommittee for the time sensitive medical advisory committee. When someone figures out how to pronounce that acronym, you let me know.
Megan, I'll just say, on our agenda for the trauma subcommittee this week will be some breakout group discussion about what you want the priorities to be. So I would very much suggest so Megan is on the committee and can bring that forward to talk about revision of big with aspirin as a potential topic for them.
Whispering. Our next priority should be looking at the minimal rib fracture. That exact patient that Matt was describing with one rib fracture, who certainly doesn't need to come from the coast of Portland. I guess it's a little easier to justify coming from Adventist to the Hill, but I think there's a lot of opportunity to provide education and support for the care of these patients while reducing general cost of the system. Patients, facilities, and food. Now this is where we stall until Dr. Joffrey unscrubs from the ECMO cannulation that he's doing, that he said would definitely be by 4 o'clock. Did we do the minutes? Oh, we have not done the minutes. Has everyone reviewed the minutes?
Yes.
Any corrections for the minutes?
No.
Would anyone? I would like to vote to approve the minutes? I'll approve the minutes. Would anyone like the second?
I'll second. Actually read them all.
I
Couldn't sleep last night thinking about, did I talk to Gilmore for survey? Writing notes to myself, I'll read the minutes to go to bed.
Glad somebody read them, because I do actually put work into writing them. I will read them. But I know that certainly all of us in this room have been working very hard on our upcoming site surveys, and oh yeah, that work should be greatly applauded and appreciated. And
Nobody wants to know our dreams, Heather.
I'm just sweet. Good morning.
Take that one. Yeah. Do you want to propose implementing the rib injury guidelines in ATAB 1? We have 10 minutes. Sure. Okay, I'm gonna recommend we propose the use of the rib injury guidelines in ATAB 1. Because I think it's gonna let us do what we did from minimal brain injuries to minimal blunt chest injuries. Like, we use them, they're good. We have yet to have a person who's been appropriately stratified to rig 1 or rig 2 in what, a year and a half of using them here, get admitted to the ICU. There's absolutely no reason to transfer these patients. And we're where we are. I think we're where we are with brain injuries a couple years ago, which is they get here and discharge from home in the same ambulance they came in.
This also goes along with the conversations we're having with the VA, with those patient populations as well, where.
I mean, we can even should we recommend, rig one gets discharged home, should we even make a recommendation that rig two doesn't need to be transferred to the level one trauma center? Because I would admit them to our ward, and I'm not sure that our ward is any better than CMH's ward. I mean, realistically, what happens is they sit in ED for 72 hours until they get delirious and then they fall. So I'm not sure that that's superior.
We do that, we need to ensure that everyone has guidelines for post-refracture management. So that they know exactly what process we use to make sure they have the same outcomes.
I mean, we can make because when we wrote it, it's been a while since we wrote the insight sheet. Because I think the insight sheet, the ATAB 1 insight sheet management guideline includes minimal rig injuries, but it's written prior to the publication of rig guidelines. So this is specifically on this.
I think conceptually it's a great idea. I think the problem is, like, once you go to admit somebody to the hospital, we don't have control over that anymore. Like, we don't have control over that process. So when you discharge someone home, that's the ED physician. You can consult over the phone. They can discharge them, and I think most of them will be fine with that. But once you're admitting, then you have to have a hospitalist that says yes. And we don't have a way to change their judgment unless we went to the CMOs of all the hospitals, and which might be okay, and tried to get them to change practice. Some hospitals might be okay with it. Some hospitalists might be okay with it. Some may not. And there's variability that's hard to address. Like, so I don't know. My experience is varied. I've had some hospitalists that were willing to admit a patient with that's like a rig 2 that just needed intensive spirometry and some pain medicine, and some that were not at Adventist. So I think it's the right thing for the patient. So I would say we could recommend it, but we probably can't refuse to accept a transfer, because then what happens is that patient sits in the referring ED for days until they find somewhere else to admit them to, or they get better or get worse or something.
So maybe we just limit our recommendation to the same recommendation we made for big one, right? Which is grade 1, patient with grade 1 injury, and no other reason for admission or observation. Can be discharged home.
We should also.
I think you could say rig 2, it's acceptable for them to be admitted at their nearest hospital, but you don't have to say they have to be or something. But I think it's nice to say they can be, because I think that just facilitates the process, but I wouldn't require it.
They won't get a tertiary exam. So if we care that all the trauma patients in the trauma system are getting that third exam that ensures that they didn't have other injuries, if we don't, then they won't. And
They go home, they don't either.
but if they're very true, strong point. Honestly, some of the conversations that we've had with Silverton, that I know is a little sappy with Big Cap, is that they want to keep these patients, but they're a trauma center, so they have to prove that these trauma patients in their registry are getting tertiary exams. So if they keep them, no one will do the tertiary exam, and I wonder if the hospitals on the coast would have that same trouble if they're getting admitted to a medical service. Now they're trying to meet the verification guidelines, things like that. Just as something to think about, not as a barrier to overcome, rather than.
Not trying to add to the trauma coordinator's work. Back home in Canada, so there is an opportunity, I don't know, but the trauma coordinator, the teacher.
Or an APP. Or an APP, but I don't know the structure.
One of the issues with trauma, if you look at every other certificate especially, there is a medicine code specialty that manages it. So like, colorectal surgeons have GI, neurosurgery has neurology, surgical oncologists have lots of oncologic medicine doctors. Trauma is the only specialty that does not have a medical partner. It's one of the reasons why you cannot get a hospitalist or anyone admitted trauma patient, because we have no partner that's a non-surgeon. So the question is, if we're trying to put this out, could we put a small course together to create a compadre of medical physicians that feel comfortable and can be our partners in trauma? And what would that look like? Would they be more willing to accept a small TBI or pelvic fracture, or rib fracture, or spinous process fracture? I mean, surely they keep, compression fractures, right? I mean, does every compression fracture come to Legacy or OHSU? So I mean, they don't probably even realize they're already keeping some trauma patients. So the question is, how do we enable them to be partners and not feel like it's something foreign?
Dr. Cook had brought up that at Kaiser, which is not trauma center, they keep isolated brain bleeds. I also happen to know they keep rib fractures because I've seen several of them after plating in my clinic. So people are seeing trauma elsewhere, and I think it's important that we have a voice as the experts to help with that education. I think it's a great opportunity. All right, now we have plans for the rest of the year. Isn't this great?
This is great.
All right,
I think it's 2.5 years.
this will be faster. I think there'll be less resistance.
As long as they all keep ending in egg, and then we can just like
Get really fun is that you have a pelvic fracture guideline.
that's true. Yeah,
I think honestly, correct me if I'm wrong, but I think one of the biggest hesitances is more around the idea of frailty, and there's a lot more coming that were being implemented now with the elderly and geriatrics consult and internist consults, on the trauma patients. And so, if the injury itself is what warrants admission, I rarely would have tried, most of those patients do end up in trauma centers, but it's more the frailty, I think, that takes where the injuries don't necessarily require the admission, but the injury plus the frailty is the difficulty. And I think that might be a model for, how to try to bridge that gap with that non-surgeon input.
We'll put that on the agenda for the summer, in addition to talking about what it will mean for Columbia Memorial to be level 3. And now I see that Dr. Joffrey has joined us, trying to share his presentation. Our focus for the QI portion of this meeting today is really focusing on pediatric cases. And Dr. Joffrey is kind enough to bring us to our attention.
Wonderful, Dr. Lodenberg. Thank you. Can you guys all hear me?
Yes.
Thumbs up. Perfect. Wonderful. So I'm going to present a couple of cases. Both were cared for at Randall Children's. And both have similar patterns of very severe TBI with different outcomes. And obviously these patients are different, so I don't want to make the conclusion that they're exactly the same. But their pre-hospital care was dramatically different because of what was going on with them. And so I wanted to present these two and focus on the pre-hospital management. And it also brings in one of the sort of challenges that we have, where we are also dealing with patients who are coming from a different state. And so how we provide feedback, how we do loop closure within the constructs of our own state system, reaching out to Washington, I think poses a little bit of a challenge, and it's something that's certainly not new. Next slide. So, this first patient.
One second,
sorry.
pause. Sorry. Just to confirm, I wasn't clear from the agenda, Megan. Is there patient identifying info in here? Just trying to figure out if we need to stop recording.
Stop recording.
Okay. I will stop it then. Sorry.